Okay, I'd like to introduce our next speaker, Dr. Kieser from Alberta, Canada. And she told me it's been like Hawaii here all week, so she doesn't understand what Howie's talking about the nice weather. But Teresa's talk is going to be on competitive flow in the operating room needs TTFM.
Hello, good evening, everyone. First, I'd like to thank Medy's Gym for inviting all of us here. This is, and for all of you for coming. Many of you heard me talk about pulsatility index or PI. Well, tonight, flow is in the spotlight, but maybe not in a good way. This talk is about transit time flow measurement diagnosis, competitive flow in the operating room. And Howie, your name should be up here because it's because of your burning desire for quest of knowledge of competitive flow that we are all here. So thank you for your inquiring mind. The background, vein grafts have almost no resistance, but they don't endure. Arterial grafts last, but are vulnerable to competitive flow. Is this a problem? Just to refresh everybody, this is a normal transit time flow trace. You have the flow in the top left corner, 61 mils per minute. Pulsatility index is a measure of resistance of the bypass graft, and an ideal graft has a PI less than 3. An acceptable graft has a PI less than 5. Anything over 5 you should question. The diastolic filling is 74% on this trace, and usually this is for left-sided vessels. It's around 66% or so. Right-sided vessels, because of the thinner, lower pressured wall right ventricle, have a diastolic filling of about 50%. Okay, so that's normal. And the last thing that we look at is the waveform. Here you have the blue is filling in diastole, and the pink in systole, which perfectly mirrors the diastolic filling of 74%. So just because you're going to see a lot of these, I just want to make sure everybody knows what we're looking at. So first of all, the competitive flow test. I'm going to just demonstrate here with my hand. Pretend this is the LAD, and Munir, thank you for showing me how to make a bypass graft with my hand. This is the LETA coming down. So here's the anastomosis. So what we do when we test for competitive flow is you snare proximally on the native coronary artery. First you measure the flow in the graft, then you snare the native artery proximally, and then measure the graft again. And what you usually see in competitive flow, and I must say, Rune, your experimental work it really mirrors exactly what I found clinically. So this, to me, was very exciting to hear your talk, because it really, it fits, you know? So competitive flow is shown when the flow goes up and the pulsatility index goes down. So the purpose of this little study, this is very new data. In fact, I finished it 2 hours ago. You think I'm kidding. I wanted to review some arterial grafts that I had measured with proximal snare and correlate that with the maximum native coronary artery stenosis to find a possible pattern and frequency of these patterns. So this patient population was just 120 off-pump CABGs from May 2008 to May 2010. And I only really use the proximal snare test in off-pump patients because you have the silastic loop around the proximal artery before you go do the anastomosis to either put your shunt in or occlude the vessel as you're doing it. So I don't use snare on pump cases unless I have a problem, but I do it if I have a problem. These statistics are for the last 4 and 6 off-pump cases, the last 9 years, but I really ramped up my off-pump in 2008, and for the last 4 years or so, almost 5 years now actually, my off-pump is about 71%. And the demographics of these off-pump patients are a little different from the on-pump. Their mean age is a little higher at 67, the same amount of men, 78%, 30% diabetics, 33% obese, 31% with a Euro score greater than 6, and they have 71% BEMA. My on-pump cases have about 73, 74%. So let's look at the results. So you cannot do proximal snare on every bypass when off pump because you got the heart in the air, the patient upside down. You just want to get that anastomosis done at the back and then drop the heart down. So you can't always measure competitive flow on every bypass, but you can do it for most of the LETA to LADs. So we are going to measure 156 of the 336 grafts, which is about 46% in the 120 patients. There were 6 veins and 330 arteries, so this is a mostly arterial study. 54% we measured of the LETA to the LAD, 17% for the diagonal. Now these diagonals were single LETA to diagonal, the first part of a sequential. I do a lot of, I like to get a big bang of my buck for the mammary, so I use a lot of sequentials, about 36%, 10% are composite, and only 55% are single. So I only use the snare, or I'm reporting the snare test today for the first part of the sequential graft because the flow characteristics of a sequential graft are another paper. It's very complex if you have a tight stenosis of the diagonal and a lower stenosis of the LAD, or vice versa. You can have all sorts of combinations of flow between the two. So there are no sequentials in this study. Then we used the right coronary territory and measured either the REMA or the radial, 16% and 13% was the circumflex territory, which makes sense because the circumflex is the hardest one to sort of keep in the air while you're doing the snare test and measuring. Okay. So on looking at this, there were 4 patterns, and this is like it's mirroring your experimental work. First, the first pattern was flow goes up and PI goes down, and this was competitive flow. Second, the flow and the PI remain the same, and this is no competitive flow. Thirdly, the flow would go down and the pulsatility index would go way up and either over or very near the unacceptable level of 5, and this was an imperfect graft. And then there was a 3B, I called it, and these are subject to anybody's interpretation or change or suggestion because this is new work. It hasn't really gelled in my head yet, so I'll welcome any suggestions or any comments on this. So 3B is a flow goes down, the pulsatility index stays the same or a little bit changed, but it's not significantly so. And this looked to be a pattern related to a very significant amount of retrograde runoff that was snared. So when if you have a lot of runoff here and you snare this, you're going to drop your flow. And I've got a very good angio to show this. So there was a 4th pattern that it was flow goes up and PI goes up. I have no idea. It might be diffuse disease. It might be an anastomosis problem. I mean, this is uncharted territory for me. So I have some examples of these transit time throw values. So this is a 50% stenosis, LEMA to LAD, and we all bypass the LEMA to the LAD. If it's a 50%, you have to. So the flow is 25, it goes to 39. The PI is 2.1, it goes to 1.4. And at the end of the case, the flow is 17, and the PI is 2.2, and you see a little bit of backward flow here. So you definitely got some competitive flow because these flows are very high and it's settling down. So this is where flow gives you an idea also that there's competitive flow. And I also want to stress it is really important to measure and measure and measure in the operating room. It takes like 3 seconds to do it. The team, I keep the machine on all the time with the sound, and every time they hear it, they go, do you want to say that? No, this is a sound test. I'm just checking. I probably check my graphs maybe 5-6 times in a case. The team threatens to take the damn probe away from me, but anyway. Okay, so here's a REMA to a ramus. And again, you first do the graph and you go, oh my goodness, PI 5.4, backward flow. I mean, this is the flow, the native flow is coming down, and here's the bypass, and it's just so torrential, it's going back up the graft. So that is what this little thing is. That's retrograde flow. So do the snare test, the flow goes up to 20, the PI goes down from 5.4 to 1.4, and at the end of the case, you've got a good pulsatility index, but the flow is a little on the low side, but that's because you've got competitive flow. Here's a 60% stenosis, 48 to 79, 1.5 to 1, and then at the end of the case, 19, 1.6. There's still quite a discrepancy between the flow at the end and the flow when you were testing it. Let's see, okay. This is another LEMA to LAD, 60%, 25 to 47, 2.2 to 1.5, and at end, you can see you have that, notice how when you do the snare test, the backward flow goes away, but it comes back when you release the snare. There's a 70% stenosis, 45 to 100, 1.5 to 1.4, and it settles out. As the stenosis gets higher, you can see the flow is a little bit higher at the end of the case. There's so much you can learn from just watching, using this device. Here is the angiogram of that last patient with the competitive flow. Here's the leta going to the LAD. Here's a T or a Y graft of part of the radial off to the diagonal. And even though there was competitive flow at the time of the surgery, this is 4 months post-op. It's okay. It's a good graft. That's not going to go down, God willing. Here's another example. This one is quite interesting. Here's the native LAD being filled, and retrograde, you're seeing the bypass grafts. And this was this is a lima to LAD, and I took the end of the lima and attached it to the lima itself and wired it off onto M2. And this is 20 months post-op. So this is definitely competitive flow, and it was competitive flow at the time of surgery. So here's the graft forward. It's fine. It's, there was competitive flow at the time of surgery, but it doesn't always mean that you're going to have a string sign. Here's another example. And this one you see only flow going anterograde, and you're going, oh, gee, there's no retrograde flow. Is my heel of my anastomosis a problem? But actually, it's not. It's just quite significant competitive flow. This was a 70% stenosis of the LAD. And looking at the native artery, see all the competitive flow? There is flow going backwards from that graft. It's just that it's so torrential coming forward that you don't see it. So those are examples of the first pattern, flowed up, PI down. Now we're going to look at some examples of flow and PI remaining the same, and that is with no competitive flow, like you showed, Rune. This is with an 80% stenosis, and the graft, okay, the flow is 33 to 31 with proximal snare, 1.3, 1.5. And at the end, look at the flow. Because this is a tighter stenosis, the flow is even higher. Like it was, the other values, remember, they were always lower than they were before. So you can learn so much. You know that there's not much competitive flow here. Artery grafts get bigger with time. If you ever take a patient back for bleeding the next day, I mean, that doesn't happen very often, does it, Joe? But I always measure the flow because, I mean, one of the arguments of, I'm going to get on my little BEMA pedestal now, one of the arguments for using arterial grafting is that people think that there's not enough room for movement or flow for the lima to take care of the whole heart. But if it's 40 one day, it can be 100 the next, because it grows with time. So here's an example of, actually this patient, nothing is etched in stone and carbon steel. Here's a patient who did not have evidence of competitive flow, but she obviously does. This stenosis was deemed an 80% in a stent, so maybe it isn't quite that bad, because there's certainly competitive flow here. And that mammary's a little small, but it was small when I did it, so. So now, the next level, next pattern is flow down, and the pulsatility index is way up. Okay, this using snare test will unmask a bad graft. So this is very important. This is an example of an occluded graft. Yes, I have had an occluded graft. Okay, here you can see the spike, the systolic spike. The blood is trying to get through the stenosis, and look at this, hardly any diastolic filling. So and of course the PI is high and the flow is low, and the diastolic filling is 27. So you go back, you fix it, and this is very interesting. What has been happening, these are off-pump cases, what has been happening that time when that graft is not working, the heart distal to it is being maximally vasodilated because it's trying to get all the blood. And so when you redo the graft and you hook it up, you have this incredible low PI and high flow because the heart is just trying desperately to get blood. And then when the ischemia resolves, you get your normal value. So you can learn, so if you redo a graft, even if you don't think you should, and you think, oh, I better do it, damn thing, it says it's wrong. And that's one thing, the Megatype says it's wrong, it is bad. If there's a bad graft, it is a bad graft. So if you redo it and you see this, you know you did the right thing. Okay, this pattern is interesting. I found that the flow went down and the PI either stayed the same, changed a little bit, but not badly so. And I think it is because we were snaring off a very significant retrograde bed. So This is an example of an 80% stenosis, 17, 14, 1.6, 2.5. The flow went down, and at the end, it's good. And again, it follows the pattern of the 80, 90% stenosis, where the flow gets better as at the end of the case. This is 100% stenosis, 45, and you snare it, and the flow goes down. The PI goes down a little bit, but at the end of the case, the flow is up to 53 because it cannot go anywhere else. So this is an example of such a case, and I want to just show you. Can you imagine, here's the lead to the LAD. Imagine if you snare right here, you're going to lose all of this retrograde flow. So it makes sense that the flow goes down in this sort of a case. So we looked at, these are the pattern types. A third, 33% had competitive flow. 36% of these grafts had no competitive flow. 4% looked like they were grafts, and 22% had that retrograde bed type thing, and then the 3% of the grafts I didn't know how to classify. I tried to correlate the degree of stenosis with this, and I averaged it out first of all, so that the competitive flow grafts, which is 33%, had an average stenosis of 68.1. The no competitive flow had 77.9, and the retrograde flow was 86.7. So there was a trend going up. But then I just added up, and this is, I don't have a statistician on this yet, and I probably need one, but I just added up the number of grafts that had 50 to 70% stenosis in type 1 competitive flow, and 80 to 90%, and 100%. And you can see with the competitive flow, most of the stenoses were in the 50 to 70% range. In the patients with type 2 or no competitive flow, most was in the 80-90% range, and then there was this combination of these grafts were in the near the 190% range. So it seems to follow a similar pattern. So to summarize these results, 120 patients with 156 measured grafts for competitive flow, 33% showed evidence of competitive flow, 36% showed no competitive flow, 23% had this pattern of decreased flow with variable change, probably due to snaring of the retrograde runoff, and 4% were possibly impaired. I like that term. It's like impaired driving, you know. 3% a pattern without interpretation yet. I'm sure somebody will figure this out. Okay, these six impaired grafts, and I'm inputting this data a couple of weeks ago, and I'm going, oh my God, I didn't look at these 6 bad grafts. How can this be? So, again, pre-snare, if you look at just the PIs, 2.9, 6.4 with the snare, that could be a bad graft. But the final protamine, it's a good graft. And with the low flow and the 80%, you know, not every 80% is 80%. That's why FFR is so useful, because some 80% are actually 60%. And this one was 26.8, 6.3, and then 2.4. Sometimes when you're off pump and you're measuring proximal snare, you've got the probe a little bit wrong, and you know your perfusionist are just grabbing stuff, and I say grab that. So, but the take-home message here is just keep measuring. If you have a bad value, you cannot make it look bad. So if you can adjust the probe so it looks good, you have a good value. That's why it takes a lot of using this to get used to it. This graft, probably when I was inputting the data, I thought, oh my goodness, this is definitely a bad graft. I went back to my operative report, and I found that I had actually redone the graft. So this was a bad graft that Medistim told me it was bad, because actually the PI was up to 5, 6, and 7. This graft was bad. It was the diagonal, and I went back to the operative note, and in my notes I'd said the diagonal was so tiny and diseased, and I had a good graft to a diseased LAD. I said, okay, that's it. I'm not going to try and repair this, because it's not going to work. And this is the one important message as well. You don't have to repair or redo every single bad graft, or every single graft that has a high PI, but you have to address it. There might be something simple you can do, like just incise a pericardium that's obstructing, or change a twist or something. The point is, you don't want to lose a bypass graft because there's a little tiny twist at the heel. So this is the value of this machine. Again, so these were good because the final value was good, and this one I felt was probably competitive flow because it was only 60% stenosis. A few examples of what I call mega type of competitive flow. This was an 81-year-old lady that had a 90% distal stenosis of her LAD, and you do the bypass off pump, and you go, oh, for crying out loud, 7, 18.1. Look at the retrograde flow. Do the snare test, totally day and night. 15, 1.5, no problem. This is the last value. This woman probably had clot in her left main that was dissolved by the time I got to operate on her. She's been on intravenous heparin. And there was another case that a young man, 57-year-old, who probably had a left main stenosis 80%. The same thing happened. I put 2 grafts on him, 2 mammaries on him, and I got the same results. And I know that this man probably has no stenosis now. I went out and told the wife, I said, look, you know, I'm not sure that he needed this surgery, but if he ever does, those mammaries will be waiting for him. So here's a story of a 74-year-old man who paid for his own CTA, found calcium in his left main, had an angiogram, was found to have a left main 60%, no symptoms at all, have to operate on him, he's got a left main. Here's the vein graft, or here's the artery, the mammary, 37, 2.3, 65, 1.1. Well, you know there's competitive flow in that one. The vein, 66 to 79, and look at the PI, it doesn't move. That's because the veins don't move. They just stay there. They don't dilate and rise and fall. There's so much you can learn from this. So here's the final TTFM before closing. The lemur's down to 20 with a PI of 2.9. The veins up to 51 with a PI of 2.2. There's the tortoise. There's the hare. Who's going to win that race? Okay. String sign around the corner. Here's an example, just the last one, 90% distal left main of a patient, and I presented this as part of a talk at EX a couple of years ago. And here's his angiogram, and you can see it's a very tight gaposis here in the left main, but this free flowing right all the way around. So I put 1 graft on. And when I was presenting this, David Taggart was the moderator, and in his lovely Scottish accent, he said, who in the audience would put only 1 bypass graft on this patient? And about 3 people put up their hands, and I was one of them. So it's not a commonly done thing. Here's the proximal snare. You've got lovely antegrade flow. Here's distal snare. Now, on the Medistim machine, there is a button that says distal snare, and I could never figure out why it was there. This is why it's there. You can actually test flow in your graft as it goes forward and then as it goes backward to make sure you haven't killed the heel. And here's with no snare. Now, I'm not suggesting that the right thing to do is to put, 1 graft on these people or 2 grafts, but I'm suggesting that we think about what we do. And don't worry, Joe, the Excel trial, I put 2 grafts on all these people. Okay. So, conclusions. Competitive flow occurs in 1/3 of the patients and seems to associate with 50 to 70% stenosis. 36% has no competitive flow and correlates with 80-90%. In 23%, the runoff bed retrograde to the anastomosis may be very significant, so be careful with your heel anastomosis. It's not just the toe that's important. Proximal snare can unmask potentially imperfect grafts. And in this series, 96% of grafts fit into one of these 4 patterns. Speculation. Competitive flow definitely exists for arterial grafts. The extent of the problem, really, I can't determine from this data. We need follow-up. There may be a problem in patients with isolated main. If we use 2 bypasses, 1 may occlude. And I think when I was talking to Peter Kapanen, he said in the syntax trial, this actually did happen. I find it uncanny how the pattern with competitive flow, the stenosis of 89%, appears to correlate with FFR 0.8. Thank you.